This is our third national neurotrauma webinar, and those who've attended before, basically the format is that we have at the moment is we present 2 cases and then there's some questions and answers. And we try and kind of cover different topics in terms of neurotrauma, both brain and spinal injuries. And in due course, we hope to have presentations from the Cork Neurosurgical Centre as well. Just a couple of things. If you are registered in the RCSI for CPS, for CPD credits, then once you register for these conferences, you get an automatic credit onto your records. If you are registering as a guest, then the certificate will be emailed to you. And we're going to hold the webinars on the first Wednesday of each month at 6 p.m. That's the time that it's going to be at, every first Wednesday of every month at 6 p.m. If you have any questions during the presentations, just post them up on the chat on the Teams, and then I'll read them out for the presenters. And Happy New Year, everybody. And we'll start with Mr. David O'Brien, who's a colleague of mine, consultant neurosurgeon at the National Neurosurgical Centre in Beaumont. And he's going to talk about upper cervical spinal trauma. Just one other thing, if you're not the presenter, turn off your mic and your camera. Over to you, David. Thanks.
Thank you, Mohsen. And what I'd like to do is just give you a presentation of a couple of recent upper cervical trauma cases that we've had, and just give you a flavour of what we see and what we do. Next slide, please, Rebekah. So I'm going to give you 3 cases. The first case is a young 31-year-old lady who was in a high velocity RTA on the 1st of September last. She had to be extricated from the car. She was wearing a seatbelt. GCS at the scene was 13/15. Brought to UCHG. Subsequently found to be intoxicated, positive for cocaine. They did a standard trauma protocol. Next slide, please, Rebekah. And part of the investigations included a CT scan of the brain. And on the scan on the right, she had diffuse subarachnoid hemorrhage. Now, this is very key. This is very consistent with an aneurysmal subarachnoid hemorrhage based upon the distribution of the blood. This is not typical of a post-traumatic subarachnoid hemorrhage, which is probably the commonest post-traumatic intracranial hemorrhage you see. The features are definitely that of, or highly suspicious of, an aneurysmal subarachnoid hemorrhage. And it's not inconceivable that a patient could have a subarachnoid hemorrhage whilst driving. I had a patient a month back, and that's exactly what happened. So in Galway, they did a CT angiogram, and that was negative. They did a full trauma protocol. Next slide, please, Rebekah. And that also revealed that she had a hangman's fracture. So she had a traumatic spondylolisthesis of the C2 vertebral body, in addition to her intracranial hemorrhage. Next slide, please, Rebekah. So she stabilized. GCS improved to 15/15 after the drugs wore out of her. She did not require intubation and ventilation. She was transferred up to our care, primarily to have a cerebral angiogram, a DSA. Thankfully, that did not reveal any intracranial hemorrhage, aneurysm, should I say, but she had bilateral vertebral dissections. In addition to her C2 hangman's fracture, she had, which is an unstable fracture, she had a C6 laminar fracture, which was stable, and she had a superior end plate fracture of the T2 vertebral body, which was stable. Bilateral vertebral artery dissections. Now, this is a bit problematic for us because she needs to go on aspirin, and we certainly don't like to put patients on aspirin in the presence of an intracranial hemorrhage. But we had no choice, and we're happy that her angiogram and a subsequent delayed DSA was also negative. So despite the blood pattern on the CT scan from Galway, this was a negative for aneurysmal etiology. We put her in a halo vest, and we discharged her a few weeks later. We kept her in for about just under 3 weeks, principally because we needed to do a delayed angiogram. And if that turned out that she had an aneurysm, then it would be a question of treating it, most likely to be endovascular rather than a craniotomy. But we didn't want to put on a halo vest, and we absolutely outruled that she had not an intracranial aneurysm. We did subsequent x-rays and finally a CT scan, which confirmed that the fracture had healed after 14 weeks. Next slide, please, Rebekah. Thank you. And this is what a halo vest looks like for those who may not be familiar with it. It's a vest, and there are 4 pins put into the skull under local anesthetic. There are multiple pin sites that you can use in case the pin sites get infected. The halo part is supported by 4 bars which go onto a chest. We need to make sure that the alignment is neutral. You've got to be very careful if you're doing this in patients who are prone, that they've got a good eye line. In other words, the vision is straightforward. Next slide, please, Rebekah. Thank you. And this is just to show that she's her DSA. She had 2 DSAs. Interval between each of them was 10 days, was normal. What you don't see here is her bilateral vertebral artery dissections, which is in the vertebral part of her neck. Next slide, please. Next case is a 40-year-old gentleman who fell off a bicycle on the 6th of 10, 2021. He was intoxicated. He had taken heroin. He was brought into the ED at Tala Hospital. He was very agitated, very combative. They had to intubate and ventilate him. His GCS was approximately 13, 14, but he was a handful. He has a past psychiatric history. They did the full trauma protocol. Next slide, please. Now, this is even a little bit more complicated, and I'll tell you later on that a lot of head injuries will have there'll be polytrauma. In this case, he had a significant craniofacial injuries. Now, the problem with this guy is, as you can see from the scans on the right, the bony windows, he's got fractures to his frontal sinus. Not only that is that, and you'll see with the spinal fractures, if we're to put on a halo vest, the pin sites in the frontal bone, we've got a problem here because he's got a fracture. But in addition to that, he had a lot of road rash over the scalp area there, over the frontal part, and we certainly weren't going to put any pins just yet. The other thing to note is that he's got pneumocephalus. So he's got connection from the environment into his intracranial cavity. Thankfully, he had no CSF leak. So what we did initially was he was intubated, ventilated, transferred to our care, and we just monitored him for a while to make sure he's no CSF leak. Because now if we've got a patient who has some spinal fractures, which I'll talk about in a second, if he's got a halo vest in, that's going to be difficult, but we don't want to take it away and then find out you have to do a CSF repair. Next slide, please. So this gentleman had a number of fractures. He had a Jefferson fracture. Jefferson fracture is a fracture of splaying of the C1 vertebral body, where he had fractures of his anterior and posterior C1 ring. He also had a type 3 Thorn-type peg fracture. Next slide, please. In addition to that, he had a fracture of his occipital condyle, unilateral, and he had subluxation of his an anterior subluxation of his occipital C1 condyle. That was reduced. He did not have a dislocation, which is one of the cases that Catherine Moore presented a couple of weeks back. So this is a complicated case because he's got craniofacial fractures. He is agitated, combative. Thankfully, he had no CSF leak. Thankfully, we didn't have to do any facial fracture internal fixation with our Max Fax colleagues. He did not require, thankfully, a CSF repair. So once he settled down and we extubated him, and he was, GCS of 15, mildly confused, so 14 to 15, and we figured that we did not need to do any craniofacial fractures or repairs, should I say. We had to treat this. So just going through the 4 type fractures here. Occipital condyle fractures, if they're just a single fracture, you don't need to do anything about it. It's only if it's subluxing, recurrent subluxation or dislocation, or they're comminuted, then you may need to do some sort of occipital cervical fixation. But he had a single fracture which had reduced. Jefferson fractures, they tend not to have any neurological compromise, and they're usually treated with a halo vest. The type 3 odontoid peg fracture also tend to be treated with a vest with a high union rate. If it's type 2, they tend to require an odontoid peg screw or whatever type of fixation you like. In addition, he had a C5 spinous process fracture, which is stable. As I said, we put a delayed halo on this gentleman. We like to put them on pretty quickly in isolated single level fractures which are unstable of the upper cervical spine, because you get them up and about and mobilize them. You avoid the problems of recumbency and get them home ASAP. In this gentleman, we delayed it because of his craniofacial injuries to make sure there was no CSF leak, etc. He was subsequently discharged home on the 1st of December. Next slide, please. Third patient is a gentleman who went to a funeral, had a few too many jars coming down the stairs, fell downstairs, and he was brought in by ambulance directed to Beaumont. He was very confused, very drunk. He had significant craniofacial soft tissue injuries, lacerations, and he had significant medical comorbidities. Next slide, please. This gentleman also had a Hamann's fracture. Next slide, please. And this is going through the right and left side, so you can see the pars defect on either side. Next slide, please. He also has the vertebral arteries at the canal of the foramen transversarium at C2 were compromised. Like the case number 1, he had a non-flow compromising bilateral vertebral artery dissections. And again, this guy needs to be on aspirin. He did not require any neuroradiological intervention. Next slide, please. So he had a hangman's fracture. He had a right C3 facet joint fracture, which is stable. He had bilateral vertebral artery dissections. He had a halo vest inserted, applied, should I say, and discharged home Christmas week. Next slide, please. He'll be due for a CT scan in the next week or two. So just give you some background with regards to spinal trauma as we see it. You know, they occur, depending on what literature you look at, between 2 and 12% of blood trauma. Patients with spinal injuries have, in half the case, will have other injuries, and 10 to 25% of serious head trauma will have spinal injuries. Okay, it's not unusual that you can miss upper cervical fractures or trauma, particularly in patients who are intubated and ventilated, particularly in patients who have alcohol or are intoxicated. And you can imagine, in relation to spinal cord injuries, which is different from spinal vertebral injuries, there's a significant economic burden both to society, and obviously the human costs are huge for patients who've got complete spinal cord injuries. Next slide, please. So in relation to the cervical spine, just a few points that it is the most mobile part of the spinal column. And if you differentiate between spinal column injuries and spinal cord injuries, the ratio is about 8:1. So we see more spinal fractures without neurological deficit than with a neurological deficit. And of course, you can have spinal cord injuries without overt radiological compromise. And it's obviously more common in men than women. Well, I shouldn't say obviously, but it is. Next slide, please. So if we look at the probability of neurological deficit in relation to cervical injuries, with atlanto-occipital dislocation, it's approaching 100%. And Catherine gave a great presentation a couple of weeks back, you know, a phenomenal case that she did. In an atlas, like a Jefferson, where you get the ranges splayed out, it's unlikely to cause neurological compromise, even to the nerve roots. However, if the axis C2, yes, about 10% will have, depending on the amount of disruption, depending if it's isolated or not, depending on the degree. But generally, there's about 9% chance you won't have it. But what you want to do is that if you've got a patient who's got if they're neurologically intact, is you want to maintain that. In the subaxial spine, it's about 6%. If you get a unilateral facet joint dislocation, 6%, and if it's bilateral, it's very high. I can remember one case that I was involved with, 2-3 years back, who had bilateral cervical facet joint dislocation, and the ones I have seen prior to this had all neurological deficit. This guy did not have it, and we actually had to reduce them and fix them afterwards, and he was perfectly fine. The reason he did so well was his spinal canal was so big. It could accommodate a dislocation bilaterally. Next slide, please. So the risk of neurological injury with spinal fractures plus or minus dislocation is about 40% in the cervical spine, and it's low in the lumbar spine. And the reason it's low in the lumbar spine is that spinal cord ends at L1. Below that, you've got the cauda equina. Spinal canal is usually bigger, and therefore there's more space. So even if you get a significant burst fracture, if the mid and lower lumbar spine, despite the radiological compression of the spinal canal, there may not be neurological compromise. Thoracic lumbar region is about 35%. It's a fulcrum area. The spinal cord gets a little bit swollen at that level. Just at the cervical dorsal junction, spinal cord gets a little bit swollen at that area, and therefore the canal cannot compromise as much. Just remember, if you find that you've got a spinal fracture at one level, there's a probability, depending on the literature, 5 to 30%, that there's other fractures, as we've seen in all these cases today. All of them have multiple fractures. I've been referred one 2 days back, and this lady has, although she's neurologically intact, 3 fractures in her spinal region, cervical spinal region, should I say. Next slide, please. So the way we, as neurosurgeons, would classify this, and we would look at, like in the head, you'll have intradural and extradural. In the cord, we would look at spinal trauma in terms of intrinsic or intradural and extrinsic or epidural. The intrinsic would be subdural hematomas, which we would see, primarily the ones I've seen that come across patients who are anticoagulants. You get a traumatic subarachnoid hemorrhage, you get contusion, cord transection, cord edema, hematomegalia, dural tears, root avulsions, and more extrinsic ones, the more common ones we'd see would be trauma, would be fractures, dislocations, subluxations, disc herniations, bone fragments, etc. Next slide, please. We would look at the cord, or the spine, should we say, as 3 units. We look at the structural unit, we look at the neurological unit, and obviously we look at the vascular component as well. Okay, not that we would normally do angiograms of the spinal cord itself, but it would not be unheard of that we would do either CTAs primarily or formal angiography if we're concerned about problems with the vertebral artery, particularly in the upper cervical region. Okay. Next slide, please. There's a clinical aspect to this as well in terms of spinal cord injury, whether it is complete or incomplete, and that has importance in terms of the prognosis of the injury. We would look at it in terms of, in relation to a neurological examination. Clearly, the patient needs to not be intubated, ventilated, whether the problem is primarily of the anterior spinal cord, whether it's in the central spinal cord, whether it's in the posterior aspect of the spinal cord, or whether we've got a Brownson cord. And therefore, just on a clinical examination, particularly an examination, you can come across with a high degree of accuracy in terms of the spinal cord problem. Next slide, please. We're probably more familiar with central cord syndrome, where there's motor paralysis of the upper limbs more than the lower limbs. And the reason for that is if you look at the corticospinal tracts, the medial aspects of that are mainly of the cervical region. Next slide, please. So we've got to be very careful of associated injuries, because we do see a number of spinal fractures coming to us because they come to us because of head injuries. We've got to be very vigilant that we don't miss any of them. Okay, and you've got to be very careful, particularly in pelvic trauma patients, that you're not missing a head injury or an upper cervical fracture, which can occur. Okay. Next slide, please. As I've alluded to already, that there can be a diagnostic delay. So be very careful of patients who come to you intoxicated or who have had some drugs on board. Be very careful of those people, polytraumas, and of course, patients with head injuries And it's not unusual that you get, for example, a patient with a subarachnoid hemorrhage, collapses, bangs the head, gets a head injury. And I've come across that. There's one notable case that I remember as a registrar, whereby there was a patient that was in a bar stool, fell over, keeled over, and had contact injuries, subsequently died. And I remember it very well because when I was growing up as a registrar, we used to go to postmortems. And every Wednesday, I think it was Mike Farrell and Beaumont, we used to take us, and even when I was in SR in Manchester, we'd go to a postmortem. And I remember this man very vividly because I was involved with that case. And lo and behold, he had an anterior communicating artery aneurysm. He bled into his frontal lobes and he collapsed, banged his head, and we put him down to a trauma there. In actual fact, it was trauma related to a subarachnoid hemorrhage secondary to an aneurysmal bleed. Next slide, please. So our treatment goals are to minimize neurological injury or maximize its recovery, restore spinal alignment, correct any deformity. You don't need to get the perfect shape, but you get as best you can. Promote spinal stability, fusion of both, minimize pain. Early mobilization is absolutely critical for all patients. Minimize hospital costs and prevent secondary complications. Next slide, please. So we can look at it, spinal trauma in terms of its mechanism, whether it's a flexion compression, whether it's actually loading where you just bang your head straight into a wall, whether there's some sort of distraction, and whether there is some sort of dislocation or subluxation with it. And you can get an idea of that by just looking at the scans. Whether the patient had a facial injury, there might be a hyperextension with it, or whether he fell straight on over the handlebars, as in the second case, we had massive craniofacial injuries. Next slide, please. So just to give you some idea about in the second case with the Jefferson fracture, this is a splaying of the C1 ring anterior and posteriorly. Because the ring is pushed out, it's away from the neurological unit, so you're unlikely to get spinal cord injury, and it's unlikely also to get any injury to C1 or C2 nerve roots. It's usually best treated with a halo brace. Now, on occasions, it may not be possible to do that because a patient is very frail, and you might decide that they're not going to mobilize anyways. Okay, but by and large, if you want to mobilize a patient quickly enough, they have no other injuries, they have no other reason not to put a halo vest on. So if a patient has, for example, a flail chest, you cannot put this jacket on them, this halo vest. But by and large, the best treatment for a Jefferson fracture is a halo brace, and get patients mobilizing as quickly as you can. Next slide, please, Rebekah. This is a type 2 fracture where, if that's the case, union is unlikely, and the best way to do it is a single trans fracture fixation or a Don-type peg screw. Some authors put in two, some surgeons put in two. I've never put two in. I don't think the dens is wide enough to accommodate two lag screws there. Next slide, please. With a hangman's fracture, this is a traumatic spondylolisthesis. It can be associated with some angulation of the bone or a translation of the bone. And if the more disruption of the bone or it's out of alignment, then you can imagine, wow, there's going to be an awful lot of soft tissue injury there, i.e. ligamentous and disc at the C2, C3 level. We can classify it. There's an Effendi, there's others, Effendi classification, but there's also other modifications of that. Next slide, please. And the classification is dependent on whether there's alignment, how much is the disruption between the bone fragments. If there's angulation and they've come across 11 degrees, I don't know why they come across 11 degrees. I thought 10 degrees might be nice, but they come up with 11. I don't know where they got that, or whether there is translation whereby the bone fragments are out of place. And you can see with a 2A or a 3, there's a 4-point classification here. There's going to be a lot of disruption here. So what you need to do is, if there's things are out of place, you need to reduce them and maintain them. And in maintenance, it's usually a halo vest. But if you've got, say, type 2A or type 3, there's a lot of disruption there. The disc is gone. Then you need to do an internal fixation, which could be anterior, posterior, or a bit of both. Next slide, please. So the principles are, in general terms, is do we need to operate or not? If you don't need to operate, don't operate. If you think that you do need to operate, well, why are we doing it? So the first thing you got to ask yourself, or this is what I'd ask myself, is there neurological compression? If there's neurological compression, then we need to decompress, particularly if the patient is symptomatic. If in that decompression I destabilize, then you need to stabilize. If there is dislocation or subluxation, you need to reduce it, you need to retain it, and that's usually with a stabilization. But sometimes you may not need to do that in certain cases where you reduce it, you retain it with a halo vest. Obviously, if there's any instability, and there's many ways of defining instability, depending on what level of the spine you're at, you need to stabilize it, either externally or internally, and obviously rehabilitation is absolutely key to all of this. Next slide, please. So again, we got to think of, okay, how do I approach this? So for example, if you've got a type 2A or a 3, a hangman's fracture, you can reduce it, you're not going to retain it because there's so much soft tissue injury there of the disc. So some people would say, what I would probably do is a C2-3 anterior cervical discectomy fusion, put a plate on front, turn the patient over, and put some posterior fixation there. You can do a C2 transfracture screws or C1, C2, C3 fixation. So the approach is, do we go front, back, or front and back? Do I do it in stages or one stage? And when do I do it? Okay. Next slide, please. That's me. If I'll take any questions now or later.
Thanks very much, David. That's a great summary of essentially upper C-spine, C1, C2 fractures. We're lucky that 4 of the neurosurgeons in Beaumont deal with spinal injuries and complex spinal procedures, which means in people who have head and spine injuries, there is expertise to deal with that. There's a few questions that have come in, David. If I can go through them. You emphasized the issue of delay in diagnosis and avoiding that. Have you any tips on that? Is it, you know, was it more in the days of X-rays rather than CTs, or should we have a low threshold in CTing the spine? What are the tips?
Well, I would actually go back to the history and find out as much as you can from what happened. Was this a high velocity injury or not, or was it a fall from a height? So if we go back to the mechanism of injury, you get a good idea. You get an idea if you look at the type of, if there's a lot of facial injuries, you think of, okay, there might have been a lot of hyperextension here, or there could be a dislocation. So history, the exam to a certain degree, a lot of these patients will be intubated, ventilated, but then the radiological imaging, and you know, for a CT brain, not so much facial bones unless indicated, CT cervical spine, and when you do a CT thorax, abdomen, pelvis, with the NIMS system now, you can just reformat it, do sagittal reconstructions, you can magnify it, and that's where I go from there. Okay. If in doubt, and you get some patients who will come to us and they've got wedge fractures, and you don't know if they're old or new. That's where I depend on an MRI scan. So I'd only do an MRI scan if I want to know is the compression that we see radiologically on plain X-rays or a CT scan, is it old or new? Or if I think, you know, if there's a lot of soft tissue injury there, because that may tilt me towards doing an internal fixation in somebody who's got seemingly a stable fracture. However, you look at the scan, you do an MRI scan and say, wow, there's a lot of disc injury, a lot of ligamentous injury. You might need an internal fixation. So that's where I go from.
That's great. And just in terms of the original, you know, in some of the dislocations that you were showing, and you were talking about reduction, how are you actually achieving that? Is that something you do on the ward? Is it something you're doing in theatre? Is it with the halo? And I mean, old days there were the traction mechanisms and things.
There's the Gardner wells is what we'd normally do. So for a subluxation, you'd use that. For talk about the cervical spine now. So for a unifacet dislocation on the ward with Gardner well tongues, the case I mentioned about the bilateral dislocation, which up to a couple of years back, they invariably had neurological compromise. They always had to be reduced. I only had one case that was, despite a bilateral dislocation, was neurologically intact and stayed that way. But if you want to just reduce on the ward, Gardner-Well tongs, and bring up the weights according to the level of which the cervical spine subluxation is. And then when they've reduced it, then you need to retain it. And I'm speaking in general terms now. If you need to retain it, it's an internal fixation.
Very good. And there's one other question in terms of, you showed the cases that you managed with the halo. Does age play a role in deciding whether an unstable spinal fracture is managed in a halo or surgically? Would age matter? Yeah.
Well, so I don't think elderly people really tolerate a halo vest. So there is a morbidity with it, and changing pin sites is no big deal because there's little holes along the halo that we can change, and that sometimes occurs. It actually happened with case number 2 there, because he had a lot of facial trauma and soft tissue trauma, so we delayed because we put the pin side in. I was worried about it, but I did have one case that I remember when I was in Australia many years back, where a guy fell, but he also used to tighten his own screws. So you have to see the patient regularly to make sure that there's no loosening and there's a gate. He actually penetrated his head. He presented with seizures or epilepsy and a brain abscess. So to answer your question, you got to see what's the social support. So the second guy also, I'm conscious of time here. He was the guy who was taking heroin, fell off his bicycle, combative, difficult guy. We have the sites with us here. He lived alone. And we're quite concerned about him, but so far he's been okay. He wants to go home. We have no reason to hold on to him. So if elderly patients, they don't tolerate it very well, in which case you might need to compromise. In which case we say, okay, we need to fix this. In which case we'll fix it. I think it's important that you give the patient the option. Then you say, here's the options, but I would go for internal fixation here or whatever.
That's great. So there's multiple factors you take into account of. Thanks very much, David. That's a great summary of upper C spine fractures.
Thank you.
Our next presentation is by David Johnson and Mr. Ben Hussein on neurotrauma, advanced age and anticoagulation. And we're also lucky to have Dr. Carl Ewins, one of our hematologists, because there is an implications here, obviously, as you see from the anticoagulants. Okay, go ahead, David. We can't hear you, David.
Mute. Can you hear me now?
Yeah, that's perfect.
Better. I'm just going to give a talk on neurotrauma, advanced age and anticoagulants for Mr. Hussein's service in Beaumont, and we're going to base it on a case we recently did. So can I get next slide, please? So our case presentation is a gentleman. He's a 77-year-old male who presented to the emergency department in the Beacon with approximately 1 month history of what his wife describes as cognitive decline, decreased mobility, increased need for support, and loss of his independence in his ADLs. He had previously been driving and very independent. His GCS was 14. He had no focal deficit, which was interesting, and his medical history was that he was had AFib and was on Xarelto, and his GP had commenced him on lithium for bipolar, but it had no levels checked. He was hypertensive and a non-insulin dependent diabetic. Of note, he had a previous burr evacuation in the Beacon 10 years prior. Next slide, please. So these are 2 slides of his scan. As you can see, he's got a left-sided fluid collection that's causing mass effect on his brain. I just took 2 slices, one higher up where you can see the kind of mixed density of the fluid, where it's darker at the top and brighter at the bottom. And then on the second image on the right, you can see the mass effect on the ventricles and the compression of the brain from the collection, and also the fact that you can see his burr hole, his previous burr hole is sitting there, and there may well be a membrane or an attachment there. And he does have midline shift as well. Obviously, the mass effect is clearly seen. So he was transferred across to Beaumont with a plan. Obviously, we linked in with both the hematologist in the Beacon and our hematologist here. Next slide, please. Basically, we contacted our hematology colleagues, and he was given vitamin K and 3,000 units of Octaplex per their advice, and we can obviously discuss some of that later on. So basically, I'll just have a quick chat about what chronic subdural hematomas are and the pathophysiology and some of the numbers that are important to us. They're between the arachnoid of the brain and the dura mater surrounding it. There's a lot of theories in the research as to the cause of it. Obviously, trauma is the primary cause for most, but as to the propagation and the development of them, there's thoughts on that. Hyperfibrinolysis, chronic inflammation, which drives vascular generation in the membrane surrounding it, which then causes poor quality blood pressure, or sorry, blood vessels to form, which then rebleed, and then again this hyperfibrinolysis causes this buildup, and also an oncological pressure gap between the fluid itself and the blood drives fluid into it. There's a very high prevalence. We say one of the studies I saw was 20 per 100,000. An incident rate obviously depends on age, but in over 80s, it's 127 per 100,000. There's a wide range of recurrence rate after either medical, surgical, or conservative intervention, but up to 40% in some studies. So the treatment plans for one of these patients when they come to us is obviously conservative management, depending on the size and their clinical condition, surgical intervention, of which there's two main types, which is burr holes, which is small drill holes in the skull to allow the fluid out, or a craniotomy, which is a removal of a section of bone temporarily. And then one of the newer techniques is IR guided intervention, which we'll have a very brief chat about later. And one of the important things, I suppose, as we're talking about a trauma conference, is that the trauma that caused it is often weeks and weeks and weeks prior, regularly up to 4 to 6 weeks beforehand. In many cases, the patients themselves don't actually remember the trauma, particularly in elderly patients on blood thinners. They can have such a very small trauma that it wouldn't even notice it, and therefore it's not something you can expect. In most cases, they'll tell you, I fell off a bike or I was hit by a car. It's very, very minor innocuous trauma. Next slide, please. So just some diagrams just to show, it's very self-explanatory. You can see the dura mater in just above the yellow, and the chronic subdural is the red there, and then the inner membrane, or the arachnoid, or inner membrane sitting on the arachnoid, is the area, and then the brain underneath it. And then of course you can see, like we saw on the CT, is that midline shift, of that compression or effacement of the lateral ventricles. Next slide, please. And this is just another angle. Again, this is not our patient, but this is with an example of a patient. And you can see, like for like there, that the subdural collection is that hypodense collection with some areas of hyperdensity within it. And that's just really to give an idea of what it looks like on a scan. Next slide, please. So risk factors. Age is a big risk factor, due to some of the things we'll talk about below. But and in males, for some reason, I read a lot of kind of literature on this, and no one seems to know why. Whether it's more trauma, more cardiovascular disease, I'm not sure, but they do show an increased prevalence. So cerebral atrophy and reduced cortical compliance is one of the big reasons. The thinking is that, you know, increased tension on the bridging veins causes them to be more susceptible to shear forces, more susceptible to bleeds, and then of course you enter into the pathophysiology of a subdural. So another risk factor was someone who has a pre-existing subdural hygroma. So an isodense collection was a pre-existing, or sorry, was a risk factor. So trauma is the main kind of causing incident. But they say in 50 to 80% of patients, they'll say they have it, but in the other 50 to 20%, they may not even remember, or they may not be able to tell you when it was. Even in young, fit patients, or well, relatively young, cognitively aware patients, you may have to say, what happened to you 6 weeks ago? I've had it myself, where he's like, oh yeah, I fell off my bike, and that's where you get the answer. Obviously, coagulopathy is involved, and then that can be innate from things like lymphomas or liver disease, and then of course anticoagulant and antiplatelet agents. So some studies have shown a 40-fold increase in the risk if someone's on warfarin other than control groups. And then one of the big the Compass trial is a big trial for factor 10A inhibitors versus aspirin, and they showed no difference between the two, but obviously an increased risk overall versus control. Next slide, please. So some of the options in play for us are, of course, hold anticoagulants and antiplatelets if it's safe to do so, and depending on the patient's clinical condition, risk-benefit analysis applies, and it may, regardless of how recently they had a stent or how recently they need to be anticoagulated, they may need to be taken off it. A lot of small-scale studies at the moment are looking into conservative management with tranexamic acid, which has showed some positive results in very mild cases, people who be GCS15 or without focal deficits. Vitamin K and Octaplex is obviously something we use, particularly in people who are anticoagulated, and then there was a large-scale trial with dexamethasone for chronic subdurals, but the results showed increased mortality and worsening 6-month outcomes, but did show a decrease in recurrence. Next slide, please. So when it comes to a neurosurgical decision after it's been referred by an emergency or a medical doctor, decisions to operate are based on the patient's clinical condition. So have they dropped a GCS? Have they got, as our patient did, issues with cognition, mobility, or general well-being? Are they off baseline? Obviously, focal deficit. Oftentimes they'll present with a unilateral arm or leg weakness. And then another one, even in someone who's GCS15 but has no deficit, severe headaches or being very symptomatic is an indication to operate, or in somebody who ultimately really needs to be on their anticoagulant and needs a minimum possible holiday from it. That can be an indication to operate as well. Next slide, please. So from a surgical point of view, our options are burr hole or craniotomy. So generally speaking, the burr hole is better tolerated. It's a less invasive, and for simple subdurals, it's probably the best choice. But in some cases with membrane, so the longer a chronic subdural has been there, the more likely they are to lay down these membranous layers in between them, which can prevent simple drainage with burr holes, and that can require a craniotomy. Or if they're acute on chronic, the consistency of the blood is not sufficient to come out of a burr hole. Our other decisions are drain versus not. So what we saw in multiple studies, which I've quoted later on, is that it reduces the recurrence rate and the lower 6-month mortality. So we'd always put a drain in. And then the discussion is what type of drain. So subdural, we feed through the burr hole and it sits between the brain and the dura. And then subgaleal sits sort of below the skin and scalp over the bone. A recent study in Cork showed there was no outcome differences or recurrence, but there is probably some increased morbidity with the subdural drains. If the brain is compliant and expands back up, there's a risk of brain injury with that. One of the newer techniques that is starting to be used is middle meningeal artery embolization. And there's a few trials out there at the moment, some showing increased resorption at 3 months, but having similar recurrence rates. So we're not really fully up and running with this yet. So it's still in the process of being looked into here, and there's a talk in the future coming about it. Next slide, please. So we have a couple of slides just to discuss what the level of input neurosurgery has in Beaumont with this. So a recently published trial by Mike and Moo, who's previously discussed here, and they looked at from January to December, a 2-year period, and showed 300 cases of subdural were referred. As you can see, 200 were chronic, and of that 200, 198 were operated on. They had a recurrence rate of 26%. And of that re-evacuation rate, 23% were re-evacuated. We have 2021 data is still under review, but at the moment the numbers I've gotten are that we had 270 combined traumatic brain injury and subdurals were referred in the first quarter of the year alone. But of that, we had 120 subdurals that were accepted for admission. We don't have all the full data on that, but that's 120 within the year. So it's still, as you can see, an extremely common occurrence for us to be referred, accepted, and operated on. So it is quite a lot of resources required for it. Next slide, please. So just basically to tie up the last of the talk, I looked up the most recent kind of either large-scale trial I could see, and it was a Chinese trial from 2020 in the British Journal of Neurosurgery, and they followed up almost 600 patients over a 3-year period to look at what their anticoagulant status were. So they looked at anticoagulants versus platelets. What they showed, some of the interesting take-home points were there was less amounts of trauma reported in the anticoagulant or antiplatelet agent groups. They couldn't remember it, or they didn't think they had it. So obviously the less severe or more innocuous traumas were seen. They often had worse clinical condition at presentation. Next slide, please. The recurrence rates, so in the anticoagulant group, were approximately 20%, which was significant versus the control. But the antiplatelet group was only 12%, which they did not find that to be significant. And they showed that the recurrence timing was most likely 1 month from surgery. So next slide. So essentially, that's just the references. So I looked up a lot of the kind of the basic papers that we had and some of the issues there. So that's really it. Our patient, just to tie it up, is doing extremely well. He took a couple of days to kind of recover, but now he's back to his near baseline. He's ready for home almost. We're going to give him a little bit of convalescence, but he's back to, you know, very close to his baseline, and has done very well for us. So I'll take any questions that might be had now.
Thanks very much, David. Good presentation. It's an increasing problem, really. This is probably the commonest type of injury that we actually deal with, becoming more and more common because the population is getting older. I think all specialties that deal with trauma and all aspects of surgery are dealing with more and more elderly patients just because the age of the population is increasing. I think both your talk and David's talk mentioned falls, and falls from a height of less than 2 meters is actually the commonest reason for a patient to come to hospital as a result of trauma. So 60% of the trauma that we see, both here and internationally, really in most countries, falls less than 2 meters is actually the biggest reason for trauma. And then anticoagulants on top of that, so elderly fall on anticoagulants leads to the sort of problem that you've just shown. I would like maybe to ask Carl Ewins, our hematologist, if it's okay with him to make a bit of a comment on the problems that and how to deal with the issue of anticoagulants, particularly the newer anticoagulants. And Carl, I'll be very honest with you, neurosurgeons absolutely hate anticoagulants. So you might just fill us in, particularly on the newer anticoagulants, and what can we do in this sort of setting where someone has intracranial hemorrhage and then they're also on one of the newer anticoagulants.
No worries. Thanks, Mohsen. Thanks for asking me to tune in today. Excellent presentations. Well done, David, for summarizing such a difficult case and going through the data so well. So I guess most people are familiar with warfarin anyway, or at least there's going back a while, we're more familiar with warfarin. And what was easy about warfarin was that there was a reversal agent that we can give vitamin K, which will take effect maybe 6 hours down the line. We can give PCC, which works right away and replaces those vitamin K dependent clotting factors. Not completely, but it does have an immediate effect. The advantage of the DOACs over warfarin is, when I say DOAC, I mean the direct oral anticoagulant, is that they're much more convenient, and actually the rate of intracranial hemorrhage is about 50% less. So we should be seeing less intracranial bleeding than we would be on warfarin. There are 4 main DOACs on the market. 3 of them are directly inhibit 10A, factor 10A, so they're anti-10As. And one of them is a direct thrombin inhibitor. So the direct thrombin inhibitor is dabigatran. The other ones are apixaban, rivaroxaban, and edoxaban. And most commonly, people will be on apixaban or rivaroxaban for either atrial fibrillation, for VTE, which is what I'm often seeing them for. So the problem with the DOACs is that aside from dabigatran, there's no reversal agent available in Ireland. So dabigatran has, also known as Pradaxa, has Praxbind or idarosizumab. There are about 3 doses in Beaumont at any one time, and what that can do is it can be given to somebody who comes in with intracranial bleed, and it can reverse it. Has a pretty good effect of reversing it immediately. But the bleeding rate with dabigatran is slightly higher, and it's not used. Its use isn't as widespread. There is an agent that it will be available for the reversal of andexanet of the other DOACs, and that's called andexanet alpha. and it is like has been approved internationally, but it isn't currently licensed in Ireland. And they're kind of dragging their heels about that, and probably for good reason. It's very, very expensive. So I don't know what the final dosing will be, but you can expect it to be anywhere from 5 or 10 grand a dose, possibly even more, depending on what they agree. But there's a high thrombosis rate with this reported in the studies that were published, and kind of reports are that it's about as effective as PCC, which is what we use currently. So I guess when I get involved in a case like this, it's usually somebody's come in the door, they have an acute intracranial bleed. That's usually it. Sometimes it's a chronic subdural, like what David presented, and they either have to go to the theatre or they don't, and I'm asked what to do with their anticoagulation, how do we reverse it? And normally my answer will be, we don't have a reversal agent for these DOACs, but what we'll do is we'll try to optimize the coagulopathy as much as we can. The first question is, do they actually need to go for surgery right away? So if it can be delayed at all, that is preferable. That's particularly somebody who doesn't necessarily need a surgical intervention. If it can be delayed, that's great. But if it can't, if it's felt that this bleed is life-threatening and that urgent intervention is required, or just that we need to stop the bleeding acutely, we can do things to optimize it. So I know you mentioned for this patient he was given vitamin K. So the vitamin K wouldn't have had any effect on the rivaroxaban at all. What it might have had an effect on is, say, if he had a dietary deficiency in vitamin K clotting factor, depending on clotting factors, that's possible. It would reverse that. But giving it's fairly harmless to give, so it was probably given for that reason. But for him to go for his surgery, he needed something to offset the effect of the rivaroxaban, and he was given PCC, prothrombin complex concentrate. Now, this isn't a reversal agent. It doesn't undo the effect of rivaroxaban at all, but what it does is it allows the patient to make a clot, it allows them to form thrombin. And the issue with this is that you can overshoot if you give too high a dose, or if you give it like too long after the anticoagulant was given, you can overshoot and actually precipitate a thrombosis. So that's why we're judicious with our use of it. So what I would suggest, anybody comes in the door and they have a bleed like this, is that you refer to the guideline that's on the internet in every hospital. I know this is a national talk, so every hospital should have access to a reversal of DOACs guideline, and some will have a specific reversal of DOACs in intracranial hemorrhage guideline. And they all taken from the same documents, and basically they'll give a stepwise a way to deal with the bleeds, whether it be mild, moderate, or severe. I think if somebody has an acute intracranial bleed, it'll be severe, and invariably we'll be advising give PCC plus minus tranexamic acid. We probably didn't advise tranexamic acid in this patient because I think it wasn't an acute bleed, and it was sort of had happened a few weeks ago. And this was just to offset the effect of the rivaroxaban to facilitate going for surgery. So I don't know if I've answered your questions there. Is there anything else that you want?
No, that's great. That covers kind of the different types of DOACs and how to deal with them. I must say, I'm just glad that you guys provide such a good service, and we can just pick up the phone and ring you and at all hours and get your advice.
We're always happy to take a call.
There is a question asking the optimal time for restarting anticoagulants, and Carl or David, do you have an answer to that? Post-op.
Well, it is sort of an evidence-free zone. We don't know the best thing to do in these cases, but it also depends on the indication and the comorbidities. So if it's atrial fibrillation, say, and somebody's a subdural hematoma, you might interrupt for anywhere between 1 to 4 weeks. But if it's felt that the bleed, that the recurrence risk is too high, you'd explore other options. Perhaps that patient should have left atrial appendage occlusion, and so cardiology should be involved in making that decision. Again, if it's VTE, it depends. Did they have their PE event within the last few weeks, or did they have it 5 years ago? So if they have it very recently, I'd want to get the back on the blood thinner sooner. If it's more distal, you could justify delaying. And if it was necessary to put in a temporary IVC filter to facilitate interruption of anticoagulation, that can be done, but should always be discussed with hematology if you're planning to do that. So there's no right answer, but I'd say in general you definitely hold it for at least a week and then have an MDT discussion.
Yeah, it very much depends on the underlying indication, and we also, with a lot of the subdurals, we would repeat the scans and make sure that it's completely gone before we restart, because often when we've restarted it too early, we've had a rebleed and then we run into problems that way. That's great. I think we are coming up pretty much to the end of the presentations. I do want to make one comment on a trial that David commented on, the DEX CSDH trial, which essentially showed that in patients with chronic subdural hematomas where we manage them non-operatively and we manage them conservatively, we've often used dexamethasone, or a lot of neurosurgeons used to use dexamethasone, and had observed that it seems to reduce the chances of the patient subsequently failing conservative management and needing surgery, or if they had operated, it reduced the chances of recurrence. And it just, when the randomized trial was done, it showed that dexamethasone did in fact reduce the recurrence rate, but other complications occurred and the overall outcome of the patients in the treatment group was worse than the non-dexamethasone group. And it really highlighted why we need randomized trials. Because there are things that on a daily basis we see, say, a benefit of, but we're not actually seeing the harms of. And that aspect of that trial was really commented on in the New England Journal of Medicine. It was a trial that was kind of run through the Cambridge Neurosurgery Department. Other than that, I think, Ben, do you want to ask a question? Do you have your hands up still?
Hello, Wilson. This is Donica.
Hi, Donica.
So I just have a quick question for Carl. Fantastic summary, Carl. Thanks very much. Just one issue with regard to, optimizing the operative conditions for operating on somebody on aspirin. Could you share your thoughts with us on that? Kind of a nightmare scenario for us is, say, a patient with a post-fossa hemorrhage who comes in and is on aspirin, and we have to do it right there, right now. And we do give platelets and stuff, but are there any other hematological pearls that you could share with us with regard to optimizing the intraoperative, and it is quite common, you spoke eloquently about NOACs and that, but what about aspirin itself, and how can we get around that?
Well, like aspirin is bound to the platelets for their lifespan, so it's going to be in the system for 7 to 10 days regardless until those platelets are replaced. So like obviously if it's an elective procedure, you want to hold it for about 7 to 10 days prior to the surgery, but if somebody comes in with an acute bleed, I would do the same. I'd be giving fresh platelets which aren't bound to aspirin. I'd hold the aspirin, if there's no way we can delay, and if they bleed further, I'd give more platelets, and we'd be happy to discuss. You could always consider tranexamic acid as well.
Could I ask a very quick question about the sort of the half-life of aspirin in terms of if the platelets are all switched off and we give new platelets, how long ago would the aspirin need to be in the system to be gone? Like if they took it 2 days ago and we give new platelets, is that aspirin still in the bloodstream, still switching off the platelets we put in? I
don't know the answer to that question, sorry.
Right. You'll probably find out at surgery, David.
Yeah. Critical evidence.
Listen, that's really good, and thanks very much for your input, Carl. I think both presentations have been really, really good, and I'm going to wrap it up there. 7 o'clock. Everybody wants to get on with the evening. Just to remind everybody, we'll run these webinars on the first Wednesday of each month at 6 p.m. So the emails will come through. And as I said before, if you've already logged in for CPS, you will get your CPD points automatically, and if not, it'll be emailed to you. Okay, thanks very much, everybody. Good evening. Bye-bye.